Hi everyone, we're going to, my ADHD is kicking in, so we're going to go pretty quickly so we can get everybody out this afternoon. Because if my ADHD is kicking in, I'm sure yours is. In any event, I'm going to talk briefly about the brain, what I call the Achilles heel of cardiac surgery. And this is of course a statue of depicting Achilles with the spear through his heel. The mythological story varies, but one interpretation has been that his mom was dipping him into the river Styx to protect him. Apparently the river's waters had this magical property of preventing him from being penetrated by any sharp device. And of course she held him by his heel, and that left that one area unprotected. As far as this talk is going to proceed, we're going to do an introduction. I'm going to talk a little bit about the incidence, the mechanism. The two main mechanisms are embolism and hypoperfusion. Then I'll wrap up with some talk about protection and prevention and some conclusions. First, the introduction and background. Neural complications have plagued cardiac surgery since its inception. We've brought them down quite a bit for conventional heart surgery, but we're still not able to bring them down to a point at which they're comparable for PCI. And that's a really important point. We've had a lot of trials come out, including the Syntax 5-year follow-up and other prospective randomized trials examining PCI versus CABG for multivessel and left main disease. And one repeated theme, and it's sort of an anthem echoed by cardiologists everywhere, is sure, you're going to have some more PCIs over the course of your life, but wouldn't you rather have that than a stroke? And for this talk, because we've spoken so many times about hypothermic circulatory arrest, antegrade, retrograde cerebral perfusion, I really want to focus in on conventional heart surgery because that's where we still need to drive that number down. Conventional forms of cardiac surgery, including CABG and valve surgery, are each associated with a defined risk of stroke. Roughly, CABG has a 1% to 2% risk of stroke, and we're talking about a flagrant, easy to recognize stroke, and valve replacement 3%. We'll see in a little bit that those numbers don't quite get past the tip of the iceberg. Importantly, once a stroke occurs, the mortality risk for the patient jumps up to 22%. So it basically jumps up 20-fold. Of the strokes that occur perioperatively, a fifth of them occur after the surgery. The inciting event occurs afterwards. The patient has woke up, may be ambulating, otherwise doing well, and then they give a sudden event. Also importantly, as we've gotten newer interventions in the cardiac surgery spectrum, these interventions in turn are notable for their relatively high stroke rates. ECMO, 10 to 15%, mechanical circulatory support, 12%, TAVR, 2 to 6%. So despite advances in neuroprotective strategy, neural complications persist. Can we do better? As far as the metabolic requirements of the brain are concerned, this is a busy slide. All I'm going to say is the one thing we have to remember is that cerebral blood flow, the requirement at normothermia, is about 0.5 cc per minute per gram of brain tissue. So it's easy. If you've got a 1,400 gram brain, you require about 700 cc's of flow to the brain. That's important in knowing when you're providing antegrade cerebral perfusion during circ arrest cases. But that is at normothermia. The pressures that usually perfuse the brain are 60 to 70 at the level of the intracranial carotid arteries. So remember, we're not talking about systemic perfusion. We're talking about the mean pressure within the skull. The pressure of the cortical veins that are reflective of the intracranial pressure are 15. That's also important because when we talk about the cerebral perfusion pressure, we're not talking about that pressure at the carotid arteries, we're talking about the difference. And that would be the 60 to 70 minus the 15. Notwithstanding, in all of us as we walk around, over the pressure range of 50 to 150 millimeters of mercury, mean, there really is no relationship between your blood pressure and cerebral blood flow. your brain tightly maintains that half cc per minute per gram of brain tissue. Within that range, under normal circumstances and when that is not distorted. In short, when supply is inadequate for metabolism, ischemia results. And what does that have to do with the relationship with the pressures? So you see in this diagram that I've put at the bottom right of my slide, you have that 50 to 150 range, during which your brain flow stays relatively constant in a normally pulsating, ambulating individual. Above that, we would say your brain flow is luxurious. And that's kind of a misnomer. If you are supplying more blood to your brain, it is luxurious as we all sit here. But when you're on pump, that's not such a good thing. Why is that not a good thing? Having more blood flow than necessary while you're on pump. Any ideas? Edema has to do with the pressures, so that has to do more with pressure than flow. How about blood flow? Absolutely, excellent. So if we just hypothesize that there's a certain amount, let's just say for air bubbles, there's a certain amount of air bubbles per cc of blood. The more blood you flow, the more air bubbles that are getting sent to the brain. So ideally, we want the blood flow to stay within the normal parameters. We don't want to send too much off. We don't want to send too little, right? Your brain compensates well when you get just below that 50 millimeter pressure. But once you get significantly below that, your ability to extract oxygen in the brain gets very limited, and you subsequently have ischemia. And this is really the final common denominator for all brain injury in the operating room or postoperatively. It's that failure of those mechanisms, whether to do hypoperfusion or whether to do with an embolus. As far as the incidence is concerned, an important source for us is the STS database. The database is excellent but limited. It's got definitions for permanent stroke, TIA, coma encephalopathy, and paralysis and the paralytic spectrum. And you can see the definitions are quite gross. For permanent stroke, a neurodeficit of abrupt onset caused by disturbance in blood supply to the brain persisting beyond 24 hours. For TIA, the same thing, but less than 24 hours. Coma encephalopathy should be self-explanatory, but it is an alcoholic patient that you've operated on, who you're having to take 6 days to get off the vent, who's just wild, non-focal. Would that be considered in the spectrum of neurological injury? We probably would count it as that, but not necessarily so, because that's more reflective of a functional problem and non-organic. And of course, paralysis, paraparesis, which is very rare during conventional cardiac surgery, but obviously during descending thoracic surgery becomes a big deal. And importantly, none of these definitions include neurocognitive deficits, mostly because we don't measure them. Even as cardiac surgeons, nurse practitioners, we wouldn't even know how to test for them. The only ones really within the cardiac surgery spectrum who knows how to test are probably our VAD coordinators, who have to test these things as part of the trials, and also our TAVR coordinators. For an isolated CABG, the STS database gives us 3.1% risk of stroke. Any neurological injury among those that I listed. For an aortic valve replacement, a little bit higher at 3.8%. Again, limited to the definitions that I've given you. Dr. Edwards, who speaks at this conference, I don't know if he's here today, published a very important paper 2 years ago in the Annals of Thoracic Surgery that analyzed outcomes of PCI versus CABG in 190,000 Medicare patients. And amongst the findings of this paper, the 30-day stroke rate for CABG was 4 times higher than with PCI. Something that gives some ammunition for our interventionalist cardiology colleagues. Let's look a little bit about whether we're really measuring what we think we're measuring and whether we can say with any confidence what our degree of cerebral injury is. Here's a study, prospective, randomized, on 196 patients greater than 65 years of age, I'm sorry, not randomized, but prospective, who underwent surgical AVR for aortic stenosis at a single center at University of Pennsylvania. At the top half of the diagram, a neurologist was intimately involved with these patients, examining both before the surgery and at periods of times afterwards. In terms of outcomes, 17% of these elective AVR cases had a clinical stroke. Of those very same patients, the STS stroke rate was 7%. So 2.5 times higher stroke rate on the same group of patients, but depending on how hard you looked and who looked. Also importantly, many of these patients had diffusion-weighted MRIs, both patients who had strokes and those who didn't. Overall, of the whole patient group, 61% had new lesions after cardiac surgery in comparison to their pre-op. Even more surprisingly, of the patients who didn't have a clinical stroke, by the neurology exam, over half had new lesions on MRI. So let's be frank. Brain injury is occurring much, if not most of the time, during cardiac surgery. What's the mechanism? We generally divide them into 3 broad categories. One is stroke, the second is encephalopathy, coma, and the third is the neurocognitive dysfunction that we've been speaking of. The incidences are depicted there, and obviously depending on what manifestation, your rate of incidence is going to be different. And neurocognitive is estimated conservatively at 20 to 30%. I'll tell you it's actually much higher if you look hard enough. The way we detect the first 2 are our usual clinical exams and guided by radiologic exams when necessary. The third is only gauged by psychometric testing. So as I said, what you find depends on how hard you look. And in a separate study, recent MRI studies demonstrate that 45% undergoing cardiac surgery have new ischemic brain lesions regardless. So we're talking of all the aortic, these are CABG patients, of all the aortic valve patients, the whole group, more than half, have new MRI lesions, and of CABG patients, almost half. When we talk about the mechanism of cerebral injury, the prevailing hypothesis is really all forms of injury arise from a similar etiology, namely ischemia, and the manifestations really depend on the extent and location of the injury. If you look at the bottom half of this slide, the form of ischemia is either embolization or hypoperfusion. One might even say that embolization is a subset of hypoperfusion. And you can either be focal, global, or neurocognitive, depending on how widespread and where it occurs. Same embolus can go to different parts of the brain and cause different problems, right? If you're down in the brainstem, for a small embolus can do a lot of damage. In terms of the interaction with other factors, the biggest problem is the ischemic insult, whether it's hypoperfusive or embolic. But I've just listed some of the factors that work hand in glove to exacerbate the injury. And I'm going to talk a little bit about them. Hyperglycemia, anemia, hyperthermia, inflammation, hemorrhagic conversion, reperfusion insult, and of course, location, location, location. So let's talk a little bit about hypoperfusion. We mentioned the autoregulation property of the brain and how it's usually maintained well within that 50 to 150 range. But there are many things that distort that curve. including cardiopulmonary bypass, on top of which patients who have hypertension, generally the curve is shifted up and to the right. Carotid disease, depending on what your serum PCO2 is during the conduct of the operation, patients with prior CVAs have a dysregulation of their autoregulation system. Hemodilution, hypothermia, anesthetics. The bottom line is that the degree of cerebral autoregulation depends on background vascular tone, and anything that affects cerebral vascular tone may distort it. When we talk about cerebral autoregulation and we're confident that if we keep the pressure and flow at a certain range while on bypass, we're fooling ourselves. One should be very skeptical in relying upon autoregulation to ensure that we're adequately perfusing the brain. In a randomized trial of elective CABG patients investigating whether MAP made a difference while on pump, 248 patients, half were relegated to the MAP of 50 to 60 and half were the 80 to 100. Both of these within the normal autoregulatory range. You can see in the outcomes when you combine neuro and cardiac complications, it's 2 to 3 times higher in the low MAP group. You triple the mortality rate, and your stroke rate is also tripled, but that last value hasn't quite reached statistical significance. In other studies, 27 to 43%, or roughly a third of patients, have significant cerebral oxygen desaturations during CABG when you measure them either by looking at the jugular bulb or cerebral oximetry. And certainly OPCAB patients aren't immune. Those of us who have been in the OR see frequent desaturation episodes, probably from a combination of decreasing the cardiac output, vasoconstricting, and raising the CVP. Another study showed that a reduction in MAP of just 10 or greater from baseline, so baseline MAP of what the patient is, was associated with a quadrupling of the risk for bilateral watershed strokes, indicating that it's probably a good idea to know what your patient's pre-op MAP was before they hit the operating room. And as I said, OPCAB is not immune. 15% of OPCAB patients experience significant cerebral hypoxemia during the course of the case. Carotid disease is also important. Remember, we're talking about the blood pressure in the vein. Now, you go from institution to institution, the attitude towards correcting carotid disease prior, during, after cardiac surgery will vary. There really are no firm guidelines. We don't know enough about it. For me, my gestalt is if the patient's got bilateral significant disease, I'll probably have them do it before the surgery. If the carotid disease, if the coronary disease is stable. If it's single critical, greater than 90%, I probably also will have them do it because I'm worried about the pressure drop off. But you ask any surgeon anywhere, they'll have different philosophies, and some are much more aggressive about doing both operations in one procedure. How about the embolic load to the brain? In patients who you do post-operative imaging who've had strokes, almost half of them are due to macroembolism from the aorta. Most of the time, encephalopathy and neurocognitive defects arise from microembolism, which are usually particles or gaseous bubbles less than 200 microns in size. This is a graph that I've just set out showing all the different types of things that I could think of that could embolize to the brain based on whether they're macroscopic and microscopic, right? Macro, most of the time, it's either a plaque from the aorta or an intracardiac thrombus. But micro runs the gamut. I've typified them into, on the surgical field, organic or inorganic. The organic ones are what comes from the patient. Fat particles, small lipid particles from the pericardial well, bone fragments, and then a whole bunch of inorganic that we always see. And I can't tell you how disenchanted I get when I see pieces of the Ratex sponge sitting inside the pericardial well. They're very small, but if it goes into a subsucker, I'm not all that confident that all these things get trapped by our arterial filters. Atherosclerosis of the aorta is a major, major league culprit, and we need to do everything we can to identify it. Certainly if we see it on chest x-ray or during a left heart cath, I always do chest CTs non-contrast on these patients, so I get a good sense before I step in the OR, no matter what kind of case I'm doing, as to what I'm going to encounter. And remember, this is just calcium, so this is going to underestimate the problematic aorta. When you make it to the operating room, as many as 1/3 of significant atheromas of the ascending aorta are not detected by palpation. Palpation, you feel a thickening. Palpation, you can feel calcification. I have many a time put my epi-aortic ultrasound and find terrible stuff within the aorta that I would have never known about. And when you find severe aortic atherosclerosis, remember that it's also a marker for severe atherosclerosis elsewhere. Epi-aortic ultrasound I mentioned, I use it routinely on every case that I do. There are a variety of ways of doing it. You can have a probe that's attached to the regular TE machine, passed over through a condom placed around it, or you can use one of the flow probe systems that are available that also has an epi-aortic ultrasound attachment. And you can grade these lesions from 1 to 5, marking how bad they are. And some of these things will dictate, as I'll talk about shortly, about changes in the way the operation should be performed. So when we're get through the chest, take the mammary down, and get ready to prepare for bypass, and throughout the conduct of the operation, there are bad things that we can do to disrupt these plaques. One is obviously aortic cannulation. You don't want to go through calcium, and you don't want to go through muck. Aortic cross clamping and release. Again, don't want to go through, and when often the clamping itself will trap it. The problem occurs when you release it. And all that stuff you crushed gets sent off. Proximal anastomosis. It's nothing more disheartening than using your 11 blade and a punch and then finding all this thick junk where you want to put your proximal. And finally, the sandblasting effect of cardiopulmonary bypass. I'm a big believer in the dispersion cannulas. I try to use them on every case to spread the pressure flow head so it's not pushing in one place in the aorta. For many years, we've known about lipid embolism from the pericardial aspirate, and depending on what you think is the risk-benefit trade-off, some have resorted to switching to cell saver for all their pericardial well accumulations. That has to be weighed against how much blood that's being produced, whether you have 1 or 2 perfusionists, and how efficiently the blood can be cell saved. But these are micrographs of what happens to a brain in patients who have died after cardiac surgery. You find these scads, small capillary arteriolar dilations, that occur because lipid material gets trapped in the microvessels. And there have been some elegant studies done, which I'll briefly review, that show unequivocally that most of these come from the pericardial well. Importantly, compared with cell saver, the A-line filter is inefficient at removing lipid. It won't. The pores are too big. The most effective filtration system, if you are going to use if you are not going to use cell saver, is using dual filtration before your reservoir. And what that would mean is having a separate cardiotomy reservoir and a filter before and a filter after it. You can see how all these manipulations start to add up. This study, performed in dogs, were divided into several groups. Essentially what was done is dogs were placed on cardiopulmonary bypass for 60 minutes, euthanized, and their brains analyzed. And 4 different interventions were done. One group had right heart bypass with cardiotomy suction. Second group had just lower extremity bypass. The third had cardiopulmonary bypass alone, conventionally, and the third was hypothermic cardiopulmonary bypass with cardiotomy suction. Those dashes you see are those SCAD counts in the brains. And you can see with the first 3 groups, they're all pretty low, between 0 and 10. And for the last group, which really the only significant deviation from the others from a mechanical perspective, had 50. All right, so somewhere about 5 to 10 times as much. Well, what are the other factors? Temperature. We all know that with rising temperature, the cerebral metabolic rate goes up, and with lowering the temperature, it goes down. That's how we protect the brain during hypothermia as well as during circulatory arrest. If you think along the spectrum of the warm patient, let's forget about hypothermia. As you see, when you get to 37 degrees and start going up, your body continues to metabolize skyward with each rise in temp. Your brain will hit a peak at about 39.5 and then will drop off because there's injurious patterns being developed in the brain with the enzymes, and the metabolic rate cannot rise higher. Unrecognized cerebral hyperthermia may lead to neurological injury on cardiopulmonary bypass, both during and shortly afterwards. Part of it is due to the proximity of the aortic cannula to the head vessels. Part of it is due to the lack of correlation of where we're measuring temperatures and your perfusion temperature. And another one is overshoot, particularly in patients that we've gone cool on, whether they were just brought down to 28 for the purposes of myocardial protection or circ arrest for cerebral protection. You all know how common overshoot is. We just never seem to get it right. Either the patient is hypothermic or hyperthermic, but when it comes to the brain, much better off being cold arriving to the ICU. I won't say the same for your coagulation system. So the question is, should we be rewarming to a cooler temperature and stopping? Here's a nice controlled trial of patients who were greater than 60 undergoing CABG. All of them were cooled to 32 degrees on bypass on a nasopharyngeal temp. The operation was conducted. The patients were then rewarmed. In the first group, they were rewarmed to normothermia, 37 degrees. The second group, 34 degrees. Neurocognitive testing was done pre-op, 1 week post-op, and 3 months post-op. You can see the temp curve of the 2 groups. They basically stayed the same during the course of bypass. During rewarming, you have separation, and then you have some after drop, more accentuated in the patients that you warmed to a higher temp. I'm not going to go into detail here, but suffice it to say that there were worse neurocognitive deficits in the group that you rewarmed just to normothermia. And it's not like we can blame aftershoot. You saw those curves. Hyperglycemia. Well, there's a profound degree of literature on the effects of hyperglycemia and brain and injury in stroke patients. The results in cardiac surgery have been mixed, and there hasn't been any definitive evidence that hyperglycemia in patients who have a stroke have worse outcomes. However, there's a lot of reasons shown here of the bad effects of hyperglycemia in patients who have a stroke, including acidosis, release of oxygen radicals, nitrogen radicals, inflammation, etc., etc. Anemia. We're in the golden age of not transfusing, right? It's a bad thing. This is a study done about 13 years ago. And it's a retrospective study. And what they did is they analyzed the hematocrit nadir on cardiopulmonary bypass and found that it was significantly associated with stroke risk. The odds of stroke increased by 10% for every change by 1 in the hematocrit. Not hemoglobin, hematocrit. Although there are cerebral compensatory mechanisms that we discussed that can extract greater oxygen from the blood, usually these do not occur with hematocrits below 30. So there's a lot of food for thought there. What can we do to make things better? Well, some of these are low-hanging fruit. And I think every cardiac surgeon should be doing epi-aortic ultrasound in the OR. It's low cost, adds little to the duration of the procedure, and can save lives and minimize strokes. It changes things. If I find a bad atheroma where I'm going to work, I always use dispersion cannulas. I modify my aortic cannulation. If I'm having to go on bypass, if I'm doing a surgical AVR, I find another site in the aorta that's relatively clean, preferably distal, the axillary artery. Or if it's a cabbage, I'm going to try to do an off-pump cabbage with a no-touch technique, which we'll talk about. Cross-clamping is a big deal. These really create havoc, both full cross-clamp and side biting. If you find significant atheroma, clamp more distally if you can, but if you can't, more proximally. If it's really bad, circ-arrest, replace that ascending aorta, do that anastomosis first, and then you can go back on pump. Or you can do an OPCAB for bypass with a no-touch technique. In terms of proximals, you can do a lot of different things, right? You can modify your technique, or you can do sequentials, Y grafting, T grafting, and so forth. OPCAB is not the savior. These are the STS results of stroke rates, raw and adjusted for OPCAB. The permanent stroke rate is 1.3% by the criteria we use with the STS definition for the on-pump and 0.9% off. Risk adjusted, it's actually slightly higher for the off-pump group. From numerous studies, there's no clear evidence that OPCAB yields lower stroke rates as they are conventionally performed because of the aortic manipulation. However, if you use a no-touch technique, basically, you don't touch the aorta. You don't put a proximal on it. You don't put any kind of clamp on it. In one study, it lowered by 60% the cerebral vascular complications. Is it all about the clamp? Not all, but a big deal. Here's a study, a non-randomized one, that evaluated close to 400 subjects that underwent neurocognitive testing at baseline, 3, 12, 36, and 72 months. This had really interesting findings. So it compared 4 groups. 2 of them were surgical groups. One was the conventional on-bypass cabbage. The second was a conventional OPCAB. Third was a non-surgical coronary disease group managed medically. And the fourth was a healthy comparison group with no evidence of coronary disease. If you look at the graphs, there was no difference among the 2 surgical groups, meaning OPCAB versus bypass cabbage. There was no difference in neurocognitive deficits between the surgical and the medically treated coronary disease patients. Is it all about the disease? Not quite, but it's really food for thought. The healthy patients didn't have cognitive decline, those without CAD. So just the very patients we're operating upon puts them at significant risk. A systematic review of all the randomized trials as of 2013 showed no benefit of OPCAB to conventional CABG. Here's a study that looked at avoiding aortic clamping during CABG. And what it found from 3 different techniques, one using a clamp, one using those proximal devices where you don't clamp, and the third, no touch. And if you look at the final set of bars, those who did best were in the no touch, followed by the device ones, followed by the clamp. Finally, embolism protection. With the advent of TAVR and the stroke rates associated with TAVR, there's a whole bunch of devices that have came to fruition. Some we had before that we use on pump, the Embolics. And there's the CardioGuard that actually suctions particles as eddies are created around the cannula. And the 2 on the right and lower part of the screen are devices, umbrella-like devices to capture debris when you're doing a TAVR. So summary and conclusions. I'm not going to, in the interest of time, I'm not going to summarize. We've just gone through all the things that can be done. But conclusion-wise, brain injury is obviously multifactorial. Neurocog dysfunction may be a correlate of cardiac disease in and of itself. OPCAB with the no-touch technique, OPCAB without no-touch technique doesn't offer any advantages stroke-wise. However, with no-touch technique has both theoretical and evidence basis that it offers better cerebral protection. As of this point in time, we don't know the cost effectiveness of some of these very expensive devices. Some strategies that appear prudent include screening the patient for aortic calcification, with studies that we normally do, intraop evaluation with epi-aortic scanning, changing your operation based on what you see on the scanning and pre-op x-ray, consideration of alternative cannulation sites, no-touch technique. It seems wise to use CO2 insufflation for the open procedures. We don't have any strong evidence that it works, but it's got very little downside. And one thing that I personally do is I don't stop my venting until I'm off pump and I'm looking at the TEE. I wean from bypass. My usual cutoff is 3 minutes. At the 3-minute mark, by that time, the anesthesiologist is looking at the echo. We investigate thoroughly for air, and only then do I remove my vent. And not only that, but after the vent is removed, we semi-continuously monitor the heart. Because I've had patients who've developed massive air emboli, even with no air in the heart, after coming off. And you want to know about that sooner or later than later. Thank you.